Hello, my name is Dr. Jose Diaz. I am Chief of Acute Care Surgery at the University of Maryland Medical Center. I've been asked to speak to you today about massive upper GI bleed in the cirrhotic patient. I do want to extend my thank you to the moderators for inviting me to speak to you today. I have no disclosures. So cirrhosis is a complex disease. The etiologies are several. Most of them are associated with alcoholism, as well as different viral etiologies. The manifestations of cirrhosis are several, but one of the ones that we're going to speak to you about today is that associated with portal hypertension and the result of portal hypertension, which is upper GI bleed. So typically the upper GI bleed is associated with primarily variceal bleed, although gastropathy can manifest itself. The esophageal varices are graded 0 through 4. And its most common bleeding can occur at upper levels of 3 or grade 4. So in patients with acute upper GI bleed, when they manifest in stable condition, these can be electively worked up or in a semi-elective manner. What we're talking about today is the patient presenting to your emergency department or hospital with an unstable manifestation of upper GI bleed. The first step is obviously start resuscitating the patient. In your institution, that may include a massive transfusion protocol. Gather appropriate laboratory, get appropriate placement of IV access, 18 or better, and then begin to resuscitate the patient. If the assumption is that there is other etiologies, then you should probably go ahead and start these patients on a PPI to assist with management. It is important to recognize that not all upper GI bleeds in patients with cirrhosis are associated with variceal bleeding. In fact, almost 55% of these are peptic ulcer disease type bleeding. Occasionally, the patient may need to be intubated for airway control due to massive upper GI bleed. And the next step should be to consult your gastroenterologist for an upper endoscopy to make the diagnosis. And then the management there continues whether or not the patient goes to the intensive care unit or is unable to be scoped at this time due to massive upper GI bleed or a late presentation and may need a Blakemore tube placement. These patients are usually pretty sick. They appear similarly. Usually the majority are male. Their ages can range, but usually within the 40 age group. And the majority are due to alcoholism, primarily just from the numbers. It is interesting to see that the child status, not only are these patients in the C category, but the B category of patients can present as well. And bleeding is recurrent. So if you are to have to place a Blakemore tube, the indications are pretty straightforward from the presentation. It's almost as if you think about it, you should consider placing this SB tube in your patient. This device has been around from the 1950s. It has gone through several versions since then. Unstable patients with uncontrolled hemorrhage, patients who don't, or consultants who don't have the right skill set, typically in rural critical access hospitals. And it's also important to recognize that over half of these patients may present with rebleeding. Patients with esophageal stricture or esophageal disease are contraindications. It is important to recognize as you're putting the tube that the tip has to be in the stomach. This should be confirmed on an X-ray before you inflate any of the balloons. The balloon are primarily in the stomach as well as in the esophagus. The tube itself has gone through various iterations itself. The Minnesota tube, if you happen to have that in your institution, has a collection not only in the distal end, but also just above the esophageal balloon. Where does TIPS fall into the management? During the initial resuscitation of the patient, it is important to recognize that TIPS is at the bottom. It should not be initially considered. Patients should be resuscitated, most commonly in the intensive care unit. You should consider whether or not they should have an early endoscopy, and if so, and if the patient can be scoped, and it is not of other etiology, it is primarily variceal, then hopefully they can be banded. And once the patient is stabilized, then you can consider a TIPS procedure. Typically, it should be once the patient stabilized to decrease the risk of potential acute hepatic dysfunction and the worsening of potential encephalopathy. What is a TIPS? The TIPS is basically a interventional radiology place connection or anastomosis between the portal circulation and the central venous circulation to allow for decreased pressure of the hepatic varices, allowing for the pressure to decrease bleeding. It is important that in any types of TIPS, especially those placed acutely or semi-acutely, that the encephalopathy can develop up to 25%. What are the indications? It is a rescue therapy, primarily used once the patient's been hemodynamically stabilized. The important thing to recognize is that there are some absolute contraindications. Primary preventive measures, this is not your initial go-to. It should be endoscopy with banding or sclerotherapy. Severe congestive heart failure, tricuspid regurgitation, or other cardiac dysfunction such as pulmonary hypertension or contraindications. Systemic infections as well as biliary obstruction in patients with cholangitis are also contraindications. Where do vascular shunts come from? Initially, Dr. Whipple, the famed Whipple procedure, was the one who initially developed this concept. Surgical shunts have been in place before, prior to the development of the TIPS procedure. It is not used that often today acutely, as the TIPS I think is safer from the perspective of lower morbidity with the performance of the procedure. The splenorenal shunt is a procedure for elective decompression of the vascular system, portovenous vascular system. It is rarely done, as TIPS is more commonly and just as effective at decreasing the pressure. But if you happen to be at a place where you don't have that ability, then I think that that is a potential option. As far as surgical management of portal hypertension, we mentioned shunts, we mentioned TIPS. Non-shunt procedures, Dr. Segura technique and other described surgical ligation techniques are available, but these are primarily of historical nature. And with that, I'd like to thank the panel as well as the moderators for inviting me to speak today. Thank you very much.